Local anesthesia. Local anesthesia is one of the most important things that comes through in the mind when we practice dentistry. Dentistry without local anesthesia would not be successful because the most important thing that the patient comes to you is for the relief of pain. Even if we are doing a cosmetic procedure, we need to have local anesthesia with us. And local anesthesia can be there for a variety of modalities such as oral surgery, periodontics, endodontics, and even prosthodontics and pedodontics, of course, because every specialty deems the need for painless dentistry. That is the mantra for a successful practice. Now, we have divided this into various lectures. So, the lecture one would be basically on the introduction, history, definition, composition, and properties of local anesthesia. We have divided this into 7 different lectures and we will be dealing with it one by one. So one of the most important things is to know how local anesthesia came into our practice and how do we apply it in our regular practice, routine practice. It's very important also to know the composition and properties of local anesthesia because it's important that we don't exceed the dose of local anesthesia, which will lead to toxicity. And this will be dealt in the subsequent lectures. So the introduction of local anesthesia would be that involves the numbing of a specific area of the mouth to prevent pain during procedures. It blocks the nerve signals, allowing the patients to remain conscious without discomfort. Earlier, when local anesthesia was not there in existence, one had to resort to the basic procedures that were done earlier prior to the discovery of local anesthesia was basically extraction, and the patient had to suffer intolerable pain because of the lack of proper anesthesia, or else in some parts of the world they used to be allowed to chew cocaine, which was topical local anesthetic, and that would provide them with the pain relief. Or else the worst thing that was done was to knock them out by using brute force and carry out whatever procedure you wanted to do. And at those times, only extraction was the sole modality. So local anesthesia plays an important role in the practice of dentistry because it allows pain-free procedures and enhance the patient comfort during the dental treatment, whatever we are carrying out. We do long procedures and majority of them lasting for many hours without subjecting the patient to general anesthesia, which is fraught with a lot of problems. The commonly used various procedures in dentistry such as extractions, minor oral surgery, root canal treatment, restorations, etc., which ensures a comfortable experience while minimizing risk and the recovery time. Understanding the types, mechanisms of local anesthetics is essential for safe and effective dental care. There are many instances where a particular untoward reaction can happen, and this will lead to unnecessary complications as well as the litigations which are on the rise in our field. So, anesthesia is always important, but the impact on its practice is not always perceived. So, what do the patients expect? So, if you look at it, the patients do not expect any pain, obviously. So, a pain-free care is absolutely important to guarantee their satisfaction and as a dentist for me to work without stress. The minute I see a patient, who's kind of writhing in pain or giving an untoward reaction by shrugging his or her shoulders would be a problem for me because I know that the patient is not comfortable, for which I need to give the optimum amount of local anesthesia, and this would lead to patient comfort while the patient is seated on the dental chair. Another thing is that in such patients, it's important that we use the optimal amount of local anesthesia as the patient could go into a state of toxicity without us realizing it is. The second thing is I want my patients to be satisfied so that they come back, and this would lead ultimately to my reputation, which will bring me new patients, and also that the patients are afraid of the needle and to be in pain. So I should practice dentistry, provide the optimal anesthesia, and see that the patient remains comfortable throughout the procedure. So undoubtedly, anesthesia is important, and the greatest awareness on anesthesia's impact on dentist priority is the need of the hour. The patient satisfaction is the number one priority on a dentist list, and this is the ultimate thing that would count for your successful dental practice. Now imagine we are carrying out a whole mouth procedure. In the earlier days, one had to resort to uh, giving some general anesthesia. However, with the advent of good local anesthetic molecules such as articaine and ropivacaine, etc., we can give a full mouth anesthesia to the patient without having subjecting the patient for being rendered unconscious during the whole procedure. However, this is not to say that general anesthesia does not have a place, but most of the patients would be happy if one can carry out the various procedures under general anesthesia. So what we see here is the different areas that can be blocked, and how we can provide the patient proper pain relief with the proper molecule that is given. And this also makes the patient very comfortable, as the patient immediately after the procedure can go back home without the residual effects of the general anesthesia. So these are the various nerve blocks which one of my colleagues is going to speak on. That is the infraorbital nerve block, anterior superior alveolar nerve block, middle superior alveolar nerve block, posterior superior alveolar nerve block, nasopalatine and greater palatine, which are there on the upper jaw. And for the lower, the mandibular anesthesia, we've got the buccal block anesthesia, inferior alveolar nerve block, and the incisive nerve block. How it is given would be dealt in subsequent modules, and it is very important to master the proper techniques so that we have ultimately a happy patient, and this leads to a lot of satisfaction both for us and for the patient. The history of local anesthesia, it was the first one was by Kohler and Gartner. They reported local anesthesia way back in 1884. In 1884, again, Halsted injected cocaine directly into the mandibular nerve and the brachial plexus. In 1905, which was one of the landmark years, it was Einhorn who discovered procaine, given by the brand name of Novocaine, and this was a significant history in the development of local anesthesia, because this provided the right molecule at that time. Of course, things have things have evolved over the years, and in 1943, Nils Lofgren, a Swedish scientist, discovered lidocaine, lignocaine as we call it, which goes by the original name of xylocaine, which was a brand name by Astra. And this was one of the most and the safest drugs, which is still in practice in a lot of places all over the world. Lignocaine is like the benchmark of local anesthesia, and it is used in so many places where patients can be immediately they can recover back to their original state. The physiology is not altered much. The problem with procaine, which is an ester molecule, is that it leads to a lot of allergic reactions or hypersensitive reactions, and this was overcome by an amide local anesthetic, lignocaine. So lignocaine is the benchmark molecule, and there are so many other developments which are there. In India, we have lignocaine, ropivacaine, and articaine, which is used in many procedures. And for longer anesthesia, we resort to bupivacaine. So we'll be dealing with them as we come to it. So the next one is, how do you define the anesthesia? Anesthesia is a loss of sensation. Local anesthesia, it's a loss of sensation in a circumscribed area of the body, which is caused by depression of the excitation in the nerve endings or inhibition of the conduction process in the peripheral nerves. There are different ways to control pain. We'll be coming to it gradually. So basically what happens is lignocaine does not allow for the conduction of the process of the conduction of pain, and it blocks it at the right place, which does not allow the propagation, and therefore the brain interprets it that way. It should be the ideal properties of the local anesthetic should be non-irritating. It should be free from producing allergic reactions. This was one of the issues with Novocaine or Procaine. It should not cause any permanent alteration of the nerve structure. It should have low systemic toxicity. Having said that, we should be very careful about the amount of molecule that we inject. Now, when we are talking about lignocaine, when we are talking about lignocaine, basically what happens is that we need to know the optimum amount of anesthesia which should be injected. When you're talking about lignocaine without vasoconstrictor, what happens is that we cannot go beyond 4.4 milligram per kg body weight and 7 milligrams with adrenaline. So when we know how much, we get a rough idea of how much the patient weighs, then it should be calculated that way. So a 65 kg individual, if you multiply that into 7, would be roughly somewhere close to 500 milligrams. That is the maximum dose one can give. This is also to say that if a patient weighs 100 kilograms, one cannot inject 770 milligrams of local anesthesia, because that will again cause toxicity. So one needs to be very sure about how much one is injecting and what it can cause. It should be, this next thing is, it should be effective regardless of whether it is injected into the tissue or applied locally to mucous membrane, and it should have a short onset of anesthesia. The lignocaine is one of the right molecules which has got a short onset of action and a medium range of duration of anesthesia. Bupivacaine has got a long onset and has got a longer duration of anesthesia. So it is important that we know what sort of molecule we are using. The duration should be adequate. The potency should be sufficient to give complete anesthesia without the use of harmful concentrated solution. It should be reversible. It should be stable in solution and readily undergo biotransformation in the body. So what happens is that it should not stay in the body for longer and unnecessarily cause toxicity. And of course, it's needless to say that that it should always be sterile. Nowadays, we get the cartridges which are available, which are sterile. The problem with the multi-dose vial that we use is fraught with a lot of problems. That in which case, where sometimes we keep the needle inserted in the bottle, which can lead to ingress of microbes. It cannot, sometimes we are used to withdrawing the local anesthesia with the same syringe, which again will lead to contamination. And it is these particular vials have got lot of preservatives in them, and this can lead to a little bit of problems such as hypersensitive reactions, even in amide group of local anesthetics. It may not be the lidocaine which causes the hypersensitive reactions, but the fact that it is usually the preservatives which are used that can cause a lot of issues, such as getting contaminated, or it can lead to problems of hypersensitive reactions. The composition of the local anesthetic, we are dealing with one particular thing. The most common one which we see here is lignocaine or lidocaine with adrenaline injection, Indian pharmacopoeia. So it has got adrenaline in varied concentrations. The one which you see here is 1:80,000. You get from 1:50,000 to 1:200,000 of adrenaline. Lower the number of adrenaline which you see, such as 80,000, obviously would mean that it has got adrenaline in greater concentration, which is not very desirable if you're dealing with a patient of hypertension. So basically, if we look at the ingredient, the first is the local anesthetic agent, that is, be it lignocaine, articaine, bupivacaine or ropivacaine. This causes a conduction blockade. That is the primary aim how it works. The second one is the vasoconstrictor, which we just talked about. And this vasoconstrictor increases the duration of anesthesia and decreases the toxicity. Even in patients who got moderate hypertension, one could use lignocaine with adrenaline, because the patient being comfortable during the procedure can be very beneficial for the patient, as the endogenous catecholamines would not be released at that particular time, which can cause untoward cardiac reactions. The third component is sodium metabisulfite, which is a vasoconstrictor, antioxidant for the vasoconstrictor. And sometimes you may see the absence of sodium metabisulfite in those bottles which are amber colored. Still, many manufacturers do add sodium metabisulfite, irrespective whether the bottle is transparent or amber colored, and this leads to the adrenaline not getting reduced. The next one in multi-dose vials is the presence of methylparaben. This preserves it's a preservative to increase the shelf life and is a bacteriostatic. And lastly, one has sodium chloride, which leads to the isotonicity of the local anesthetic solution. So these are the basic ingredients which are present. And of course, you have water for injection, which is the vehicle, without which obviously it cannot be used in almost all the cases. So you need to have sterile water, which is also there. And the basic properties of this would be that the bottle, even the multi-dose bottle should be sterile, which the manufacturer provides, and which we use it in different times. Now the point of interest over here is when you see this multi-dose vial, when you remove the cap, it has got a rubber cup, and that we pierce the needle into that and then withdraw it. So every time we use local anesthesia, even if it is for the same patient, we need to use a fresh syringe and needle so that it doesn't get contaminated. So the composition of the local anesthetic, as we talked about, is the local anesthetic molecule. The percentage of solution is based on the grams of the medicine or the drug per 100 ml. So lidocaine or lignocaine 2% implies that it is 20 milligram per ml of lidocaine. Now this is a very important figure that we should keep in mind, because one cannot exceed, like I said earlier, depending on the average weight of the patient, like if it's a 65 kg individual, 65 to 70 kg individual, then one cannot exceed 500 milligrams if you are using lignocaine with epinephrine. And if it is less than that, if the patient is hypertensive, then it becomes about 300 milligrams, which is 4.4 milligrams per kg body weight. So we should not exceed that. We should not exceed 500 in any case, even if the patient weighs 120 kilograms. So one ought to keep in mind how much of local anesthesia you are injecting. The second thing is the vasoconstrictor. So the concentration of 1:1000 means 1 gram, that is 1000 milligrams of drug, is contained in 1000 ml of solution. To produce a 1:10,000 concentration, 1 ml of 1:1000 solution is added to 9 ml of solvent, that is sterile water. Therefore, 1:10,000 means about 0.1 milligram per ml, that is 100 microgram per ml. To produce a 1:100,000 concentration, you need 1 ml in a 10,000 concentration is added. So this is the way we calculate the amount of drug that is used. Now, if we want to be very clear, and basically this is yet to be introduced in our country, we do have cartridges which is manufactured by a couple of manufacturers in the country. I think Septodont is one and one is by Orbit. So basically the cartridges which are used, they are devoid of methylparaben or chlorbutyl, which is a preservative, and it contains sodium editate. Now this particular thing is very beneficial because it does not allow any reaction to happen, basically because of the preservative. So if we look at the table on the left hand side, you've got plain lignocaine, that is 2%, Now it will have a light blue ribbon or band on the side. The green one would be 1 is to 50,000. The red one is 1 is to 100,000. And then you got different colors. Unfortunately, we don't have so many of them in our country. So this is basically in the US and Western countries where it is used. So in a cartridge, basically you got 2.2 ml and 1.8 ml. In these cartridges, you have different amount of drug which is available. So 1.8 would have 36 milligrams, while a 2.2 will have 44 milligrams of local anesthesia. And this is how we basically calculate how much of the drug which we are giving. And of course, my colleagues would talk about how the dose is given. Excuse me. Because we've got the self-aspirating metallic syringes which are useful, and also sometimes you got the self-sheathing needles and the the self-aspirating needles which are there, and this will lead to a lot of benefits for the dentist who is practicing. And this is one of the safest methods how one can carry out an extraction or any dental procedure that uses local anesthesia. So due to the presence of sodium editate or EDTA, local anesthesia evokes less reactions in patients. It is a safer thing, and we know that every cartridge that we use is sterile. The pharmacokinetic properties of local common dental local anesthetics is, the ones which we use very often are Articaine. The onset of action is fast. So is Lidocaine. However, bupivacaine is moderate, that it takes a little longer time, and Procaine is slow because the dissociation constant is 9.1. So it makes the dissociation very slow, and obviously we don't use Procaine nowadays. The lipid solubility of Articaine and Lidocaine is pretty good, and that is why the onset of action is faster. Mepivacaine, which is a very beneficial molecule, however, as of now, to the best of my knowledge, it is not available. It was introduced but then withdrawn later, and it's very cardioprotective. It does not lead to any reactions of increased hypertension or anything. So these are the various agents which we use in India, and the usual percentage is also mentioned here. So lidocaine, when we use for giving blocks and infiltration, is 2%. However, Articaine is about 4%. So the protein binding, again, which we see here, is from 65 to 95, and the duration of action is moderate for lidocaine and Articaine, while it is long for bupivacaine. And that is how we judge on what sort of molecule which you should do. Now coming to the pain management, basically it has got 4 pillars. What are the 4 pillars? I'll just talk about it. The first is the patient factor, where we consider the anatomy, age, and the comorbidities which are there. So this is something which will tell us what sort of molecule we should use and how much has to be used. So an old patient, obviously you cannot use a lot of local anesthesia because it can lead to toxicity. The second factor which is there is the practitioner's technique, whether we are using infiltration, nerve block, or intraligamentary injection. If you want to carry out a procedure in, let us say, one quadrant, then obviously you will be using a nerve block. Whereas if you want to do a smaller procedure, one can use infiltration. And if you want to extract just one tooth without any issues, that is without numbing the whole tongue and the lip and everything, one can give an intraligamentary technique, which will be very beneficial because it provides for pulpal and periodontal anesthesia. The product, that is what sort of molecule we are using, the procedure length and invasiveness. If you have carried out a long procedure, I would say that one could supplement it with bupivacaine so that the patient is comfortable in the post-operative period and the need for anti-inflammatory and analgesic goes down. And the procedure is what sort of procedure we are doing, because putting multiple implants would take a longer time. Or if you're carrying out for some procedures, oral surgical procedures such as removing a cyst or removing a deeply seated impaction, the time would increase and obviously the need for anesthesia also increases. So this leads us to the next point, that is, how do you control different types of pain? What are the different methods of controlling pain? First is removing the cause, then blocking the pathway of painful impulses, raising the pain threshold. Now, how does this happen? This happens basically with the opioid analgesics. Preventing pain reaction by cortical depression. This is by general anesthesia. And use of psychosomatic methods. That is by using biofeedback and other techniques. So removing the cause would be, imagine that if you got a nail which is got stuck to our toe, then if we remove that nail, obviously the pain would go away in some time. And the second one is blocking the painful pathway of painful impulses would be the feature of local anesthetic solution. So where all do we use local anesthesia? In practically every situation in dentistry that warrants the control of pain. So be it an extraction, maybe a putting of implants, draining an abscess, doing a bone plating or fracture reduction under local anesthesia, and obviously doing a root canal treatment or any procedure that would need pain control. So this is the end of the part 1, that is lecture 1. And in lecture 2, we are going to talk about fundamentals of impulse generation. Now we come to the second part, that is fundamental of impulse generation and transmission. So this is a very important topic which will make us understand on how it is done. So essentially what happens is that imagine a point that we are talking about where we have to block the impulse. So the impulse is like a fuse that is lit and the flame reaches the dynamite, and therefore an explosion occurs and the patient experiences pain. Now imagine if we, instead of the fuse which is lit but then you pour water over it, would be something like the local anesthesia. When you pour water over a firework, obviously it is going to get damp and it's going to stop. The similar thing happens when you use local anesthesia. If we put local anesthesia between the fuse and the dynamite, what happens is that the nerve impulse travels to the point of local anesthetic application and it dies, never reaching the brain, and the pain does not occur. So we need to know what is the resting state and what is membrane excitation. In its resting state, the nerve membrane is slightly permeable to the sodium ion, that is Na+, and it is freely permeable to the potassium ion. Now this becomes the base of understanding how the impulse is transmitted. And it is always freely permeable to the chloride ions. The membrane excitation, which is there, in the initial phase there is depolarization, where there is rapid influx of the positive sodium ions, and there is a change in polarization or polarity. The repolarization occurs when there is movement of sodium ions into the cell, and during depolarization and subsequent movement of potassium ions out of the cell during the repolarization are passive. In the next figure, we will try to understand how the sodium influx happens. That is, in the resting phase, the sodium tries to get inside, but then it is not permeable to the sodium ions, and it is the potassium is present in the exoplasm. The normal resting potential is minus 70 millivolts, which we'll see again as we come to the lecture. In the slow depolarized and impulse initiation, what happens is that the sodium gets in and the potassium is prevented from getting out. When it gets rapidly depolarized, what happens is that there is massive influx of the sodium ions, and this leads to positive positive voltage, which is plus 40 millivoltage. And when it again gets repolarized, the potassium flows out and the sodium cannot get in. So this is essentially how the nerve behaves in response to a impulse. The potassium remains within the exoplasm because of the negative charge of the membrane excitation, because of the negative charge of the nerve membrane. This restrains the positively charged ions by electrostatic attraction. Chloride remains outside the nerve membrane, and there is no diffusion of chloride through the membrane. The sodium migrates inwards because of the concentration gradient and the electrostatic gradient. That is, positive ion is attracted by negative intracellular potential, and this favors the migration. In the next figure that we will see is basically how the gates of the gates open, that is the sodium gate open. So initially it is close to the sodium ion influx, and when there is depolarization that happens, it opens up, and this leads to the sodium influx within. So what we see at the nerve membrane is a positive charge which occurs when the sodium gets in, and then again when it becomes inactive, it is close to the sodium ions. So this is basically how the nerve membrane behaves in response to a particular impulse. The excitation of the nerve segment leads to an increase in permeability of the cell membrane to sodium ions. This is accomplished, as we saw earlier, by a transient widening of the transmembrane ion channels sufficient to permit the unhindered passage of the hydrated sodium ions. The rapid influx of the sodium ions to the interior of the nerve cell causes depolarization of the nerve membrane from its resting level to a of its firing threshold to approximately minus 50 to minus 70 millivolts. Now, how do we explain that as far as the impulse propagation is concerned? So first you see which is the depolarized state where there is sodium ion. Then again it becomes negative, which is in the resting state, where it leads to the sodium ions going outside. In the depolarized state, the sodium ions come in and the balance is tried to be struck, where this becomes a constant cycle and we have the resting potential. At one point, it becomes refractory, that is, there is no effect of any impulse on the nerve, and this leads to the stage called where it is called as refractory, and it proceeds again toward being depolarized. The impulse propagation in a nerve is basically which can happen through the non-myelinated nerves and the myelinated nerves. In non-myelinated nerves, which we'll see in the subsequent slides, the non-myelinated nerves which don't have the myelin sheath or the covering of the nerve, the impulse generation goes in a straightforward fashion. This is much slower to the nerve conduction in the myelinated sheath, where you have the presence of the nodes of Ranvier. These are the nodes, and this is where you have the saltatory conduction, and this is a faster method of nerve impulse conduction. So myelinated nerves would conduct the impulse faster. The firing threshold, when the firing threshold is reached, the membrane permeability to the sodium increases dramatically and the sodium ions rapidly enter the axoplasm. At the end of the depolarization, the electrical potential of the nerve is actually reversed. So that means at the peak of the action potential, the nerve is reversed, the polarity of the nerve is reversed, and a positive electrical potential of 40 millivolts exists. The movement of the sodium ions into the cell during depolarization and subsequent movements of potassium ions out of the cell during repolarization are passive. After the return of the membrane potential to its original level, that is, as we saw earlier, which was minus 70 millivolts, a slight excess of sodium exists within the nerve cell, along with an excess of potassium cells extracellularly. This period of metabolic activity then begins, in which the active transfer of sodium ions out of the cell occurs via the sodium pump. An expenditure of energy is necessary to move the sodium ions out of the nerve cell against the concentration gradient, and this energy comes from the oxidative metabolism of adenosine triphosphate, that is ATP, which is there, which we learn every time about the energy which is required. So all this happens within a phase of 0.7 milliseconds. Now, to explain this, what happens is that imagine at minus 70 millivolts, there is a stimulus which is applied, and then there has to be a threshold. Now, if this threshold is not reached, then obviously it's called a failed initiation. So when the threshold crosses the stimulus crosses the threshold, that is depolarization, when it reaches an action potential, following which there is repolarization, and during repolarization the sodium comes out and the potassium ions which come in during the depolarization phase happens. Again, when after some time, when the repolarization leads to a state of hyper-repolarization, which will make it come back to its stage of minus 70 millivolts, which is known as the resting stage. So the action potential is a rapid rise and subsequent fall of voltage or nerve membrane potential across the cellular membrane with a characteristic pattern. Sufficient current is required, obviously, which is the stimulus, is required to initiate the voltage response in a cell membrane. If the current is insufficient to depolarize the nerve membrane to the threshold level, an action potential will not fire. So this is basically how we explain how the stimulus works. After the stimulus has initiated an action potential, a nerve is unable for a long time to respond to another stimulus regardless of its strength. So that is the refractory period, and this lasts for the duration of the main part of the action potential. The absolute refractory period is followed by a relatively refractory period during which a new impulse can be initiated, but only by a stronger than normal stimulus. The relatively refractory period continues to decrease until the normal level of excitability returns, at which point the nerve is said to be repolarized. So in this lecture, we basically try to understand how the action is initiated, what is the threshold level, and at what point the repolarization and depolarization happens. And this basically explains how the nerve responds to various types of stimulus. In the next lecture, which is the structure of the neuron and the conduction cascade, we are going to learn about the structure of the neuron and how does the conduction cascade.